items that were used there would be great therapy items. As a matter of fact, Jill and I might work on trying to get something like that for here. So anyways, what I'm going to do is I'm going to go distal and proximal on the mid-deltoid. Zzz, right? Create a little bit of gravity-eliminated abduction. I might get here and do some gravity-eliminated abduction with some help. So working the group 2s, trying to get a phasic response. In order to produce normal movement, you got to first re-experience what normal movement feels like. Why is that not truly a facilitatory technique for shoulder abduction? Anyone know?
Because the muscle that initiates abduction is the subscapularis.
You almost had that 100% right. Supraspinatus, right? Very good. Very good, Mike. So, supraspinatus is the only muscle that initiates abduction. Okay? Deltoid takes over at around 70-80 degrees. So, really, until we get up to almost shoulder level, from a pure and anatomical standpoint, you're really not doing anything if you're just stimulating the abductors. Now, where is the supraspinatus, the muscle belly lie? And the supraspinatus fossa right above the spine, right? So right in this thing here. What muscle lies over the supraspinatus? Upper trapezius does. You might go and maybe one of those friction-free surfaces, find that upper trap underneath lies the supraspinatus. So now what I'm going to do is, on the lateral end of that muscle belly, I'm going to go lateral to medial. So now my vibration is lateral to medial, and kind of across that upper trap, knowing that just beneath that you have your supraspinatus. You might be able to get a little bit of a facilitatory response that way. So it might come here, go lateral to medially, right over the muscle belly of that supraspinatus, and see if I can't get a little bit more of a response, initiating abduction. All right. Now, if I wanted to facilitate the group 1s, let me tell you, this works great. But, a pec major is a group 1. It's a shoulder flexor, it's an adductor. But if you zap right over the lateral portion of pec major, you usually get a nice little response. But that's also a muscle group that's really prone to spasticity. So I'd stay away from that. Okay, tap tendon of muscle belly, so tapping, right? So anywhere where vibration is used, we could use our tapping. So over the digital extensors, the triceps, could you right over the supraspinatus for abduction? Maybe. I might do this too. Doing associated reactions, you might want to write this in. So I'm going to do an associated reaction for scapular elevation. So in this case, Jill's pushing up on her strong side, trying to get more of a response out of her right side, while I'm also doing some tapping or vibration on the upper trapezius, which is scapular elevator, lateral to medial, lateral to medial, lateral to medial. So we're tapping, or we're doing some vibration lateral to medial. Now, yeah, you could do all this stuff on the group 1s to get a response, right? It's kind of counterproductive in terms of what we've been discussing throughout the last few weeks. Now, the next one is this. Pressure over the muscle belly. And, no, I'll leave it at that. No, anyway. So, pressure over the muscle belly, just like light touch, its sensory input. Is it real effective? Not as effective as if you use vibration or tapping. Heavy joint compression, Jill supine. And again, I want to work on proximal stability. Heavy joint compression implies facilitation. It implies co-contraction. So I might have an air splint on Jill's arm, which is something we still need to do from the elbow distally to keep it stable. So now I'm going to work on what we call a place and hold technique, which is simply proximal to distal, and it's proximal co-contraction or stability. So I might do a heavy joint compression. It looks like this. I cradle the arm at about 70 degrees of flexion, put my arm on the back of the scapula, and I'm literally doing some approximation or compression of the glenohumeral joint into that glenoid fossa of the scapula, with the arm more neutral to actually rotated. So heavy joint approximation, I'm just kind of trying to push the head of that humerus into the glenoid fossa. And then what I'm going to do is do a place and hold technique, place her arm at 90 degrees and ask Jill and see if she can hold that. So I've just tried to facilitate some co-contraction around the shoulder, and now she's going to try and hold that with some assistance. That's what heavy joint approximation will do. Thank you, Jill. And then finally, some inhibitory techniques. What is the best, probably, inhibitory technique, the most useful, the most practical? It's a what? RIP, right? Reflex inhibiting pattern. But just like we just demonstrated with heavy joint compression, light joint compression coupled with a reflex inhibiting pattern to spasticity of the group 1s can be inhibitory. Slow stroking. So maybe someone has an extensor pattern with their back, which we've talked about is pretty normal. Technically, I would use an RIP, which means trunk flexion. But technically, if you were doing something, maybe working on some trunk stability, working on just static sitting, you could technically do some light stroking, rostral to caudal, superior to inferior along the paraspinals, which is, if you want to stand up, Jill. So light stroking, again, working on maybe some static sitting balance, a little bit of an extensor tone. Technically, you could go superior to inferior along the paraspinals, those muscles on both sides of the spine. Light stroking. All right. Slow rolling, the component here really follows NDT, which simply means when we are moving our patient, it is done slow. You cannot impose normal movement on abnormal muscle tone. If you do it fast, you're going to kick the tone up. You're not going to have good movement. Slow rocking, I don't know. Again, this would probably be more for your pediatric population. Slow rocking is inhibitory to the central nervous system. Fast rocking is just going to be the opposite. Neutral warmth, I don't know. I can't say I've seen this used really in the adult population, but does anyone know what neutral warmth is? Probably some point Liat will be discussing this with you, but it is inhibitory. It can be inhibitory to muscle tone, to hypertonicities, to spasticity. And the whole thing here is, think about, any of you ever take a infant or more of an infant, not so much a toddler. So an infant, and what do? You put this blanket on the floor and put it in like a little diamond shape. I'm thinking about my days here. Pulling the top over and put the kid on the blanket, and then you swaddle them up in a certain way, right? Give them that neutral warmth, that proprioceptive input. That is inhibitory. Also, they go to sleep on you, which is probably a good thing. So, neutral warmth can be used. Again, I'm not so sure the application in the adult population. Again, inhibitory of the central nervous system. Pressure over the tendinous insertion of the muscle. every once in a while you get someone, and oftentimes this is in maybe a population that has the traumatic brain injuries, and they end up with a major Rood1 3 spastic pattern. Okay? And over time, it almost develops into a contracture, which simply means is even with an RIP, you can't get that thing fully extended. It is on, high alert. Okay, so what we want to do is have some influence on the Golgi tendon organ. So what is your insertion of your bicep? You got 2 origins, you got 1 insertion. Good. So there's an application for why you have to learn that stuff. So radial tuberosity. So what we're going to do is we're going to find that rubber band-like tendon that has an insertion at the radial tuberosity, and you're going to bear down on it. That's inhibitory to the Golgi tendon organ. So in theory, you are inhibiting that muscle. Now you can work on some further movement away from that synergy pattern. And my thumb is blanching because there's quite a bit of pressure on that tendinous insertion. So it's just more than just the RIP, more than the passive range of motion. See if you can't inhibit the Golgi tendon organ to give you a little bit more relaxation so that you can actually work with that. That would be also inhibitory. Tendinous insertion and the tendinous insertion. Biceps is probably the best example. All right.